Good afternoon, everyone. I'm really grateful to have the opportunity to speak here today. It's 4 in the morning here, but there's no place I'd rather be right now. I can see everyone now. Sounded as though everyone was having a good time. Sounded like a disco a minute ago. So hope you've had a good conference so far. Yeah, I'm a psychiatrist and a researcher, and in both my clinical and in my academic work, I focus on the cognitive symptoms of psychosis. And why do I do that? Why is it worth thinking about this? Well, that's what I'm going to talk about first. What is this problem and why does it matter? Then we're going to think about what might be the underlying causes of these cognitive impairments that we observe in psychosis. And then finally, we're psychiatrists, so we don't just want to define and understand the problem. We also think about what could we maybe do to try and help individuals that suffer from these impairments. So to start with, what actually is the problem that we're talking about here? So individuals with schizophrenia show a really substantial impairment in overall cognitive performance, which is close to kind of 2 standard deviations below controls on measures of cognition. And that's what you see here. These are basically distributions of cognitive scores. So the further you are to the left, the worse you're doing. And you can see this pronounced shift in that the individuals with schizophrenia showing here. You can see on average almost 2 standard deviations below the kind of normal average score on. You see, though, it's not a complete separation. Like most things in psychiatry, there is very much this overlap with normality as well. So that's the problem. It's a very common feature of psychosis. But why is it important? I think really the main reason it's important is because it's so tightly linked to functioning. This deficit contributes to clinical outcomes, it contributes to lengthier hospital admissions, it contributes to an inability to live independently. And then another reason why it's important to think about is because we don't really have that many good treatments for it. So, all the currently licensed pharmacological interventions, so their effects by antagonism of the dopamine D2 receptor. And this seems to work pretty well for a lot of the striking symptoms of psychosis, the positive symptoms like hallucinations and delusions, but really doesn't seem to have much direct impact on cognitive symptoms. So thinking a little bit more about the nature of cognitive impairment, this kind of shows the network structure of symptoms in psychosis. So the little nodes, the little circles, those are individual symptoms. Kind of over here, we see the various PANS items, and the strength of the line basically means the strength of correlation between these across a group of individuals, how closely they're associated. And what we've seen, depending on whether you analyze symptoms like this with a network analysis or factor analysis, we see that the structure of psychotic symptoms breaks down into basically five groups when we use the PANS. That's the positive symptoms, the negative symptoms, this excitation, hostility factor, a mood factor, and then a disorganized factor. And it's that disorganized factor which has the strongest association with cognitive symptoms when we measure cognition using objective cognitive tests. Really only accounts for a small proportion of the variance. So it seems that the information we get from cognitive testing is really fairly distinct from what we pick up with just a general clinical interview. So that's the relationship with general symptoms. But then what about when we think about the actual structure of cognition? Can that be further broken down? And like everything in science, you can keep on breaking things down. So when we look at kind of a full neuropsychiatric cognitive test battery in people with psychosis or healthy controls, we see a breakdown into particularly 7 blocks. These ones down here, kind of processing speed, general reasoning, attention, memory, and learning, and also social cognition, which I'm not really going to talk about that much, but again, breaks down separately. And these, if you fit a more hierarchical model, fit into higher order domains like this. And then an obvious question, is this something, this cognitive impairment that we see, is this something that's, particularly affecting one of these domains? Is there something that we really want to be targeting in schizophrenia, or is it really more of a global impairment? And what we see is that there's, pretty significant impairment across domains. There doesn't seem to be any domain that's particularly preserved or particularly affected more than others. Sometimes we see maybe some domains like processing speed appear to be more affected, but this is, I think, potentially a bit of an artifact of the way we test, because of course, the tests that we use are man-made endeavors. They don't neatly tie into the really kind of computational building blocks, algorithmically or neurobiologically of cognition. And so quite often what they're doing is tapping into multiple domains. And there's an interesting statistical property of these type of tests that is, when you kind of average across various tests, you get a more significant impairment than if you look at just tests alone. And this isn't something that's, due to kind of anything neurobiological. This is just a statistical artifact called the composite score effect. But what it means is if we have a test that taps into lots of things, this will sometimes tend to show a greater degree of impairment. But it's really just because it's capturing kind of a greater amount of information. So it actually seems when we look at all these different domains, it's actually fairly fair to say that the cognitive impairment associated with schizophrenia is a relatively general impairment. And a consequence of that is that it's probably also fair to, when we think about assessing cognition and when we think about assessing the effects of cognition, it probably makes sense to look at this overall composite level rather than individual domains. So the next question, when we're trying to understand, what is the nature of cognitive impairment, is, is this something that affects all individuals with schizophrenia or just some individuals? So when I showed you in that first slide, those 2 bell curves, you can see some overlap. There's some people that may have what seems like relatively average cognition, but the question you have, of course, is, well, if this individual hadn't developed schizophrenia, were they Einstein? Would they have actually had an IQ of, 140? And so even though their cognition appears normal, there's actually been some kind of deterioration. And it's relatively hard to detect this, whether we have what here is kind of shown some competing hypotheses, whether on the top we have, on the left here, we have this potential option where we have, identical bell curves of cognition in patients and controls, and everyone's basically been affected to the same degree. The cognitive performance has just been shifted along by a few units. And you can see this is reflected in the fact that they have equivalent variances. The width of the bell curves is the same. Alternative hypothesis is that actually there's some people that, get affected a lot more, and some people that don't have any impairment associated with schizophrenia. And if this was the case, what you'd see is this greater variance in the patient population. And what's nice is that you can, of course, actually study this in groups of individuals. And when we looked at this recently, this is showing here on this forest plot here. If you're further along to the right, it means that there's greater variance in people with first episode psychosis and in controls. And what we see is across most domains and in composite scores that there's greater variability in the psychosis group. And this supports this hypothesis here on the right, that there's this basically heterogeneous cognitive impairment in psychosis. There's probably not everybody that's experiencing a hit on their cognition. So our next question when trying to really define the nature of the problem is, what's the time course of cognitive deficits in psychosis? So when we look here in kind of the pre-morbid phase in childhood, longitudinal studies suggest that actually there's already some global impairments detectable in childhood before the onset of disease. And this seems to grow across adolescence, primarily due to a slower improvement seen in the psychosis cohort. When we then look at the phase over kind of the clinical high-risk phase, over the transition into full psychosis, it's very interesting to think about, is there some progression over this? Because this ties into this, age-old question of whether we can understand psychosis more as a neurodevelopmental disorder, or whether there's also potentially a kind of neurodegenerative component at this time point, in which case we'd expect a further significant deterioration over that transition period. And of course, decline in cognitive function over the illness was originally seen as a defining feature of the disorder. So over that transition period, it's not entirely clear, just because it's such a difficult period to study. It does seem that perhaps in those high-risk individuals that transition compared to those that don't, there is perhaps a slight decrease in cognitive performance, or less of an increase, because a lot of these measures, you're always getting the potential changes obscured by the virtue of practice effects. That is, people do better on repeated testing. But over the longer period, whether you do see an almost dementia-like picture, that doesn't seem to at least be clearly the case. So meta-analyses of longitudinal studies don't show a decline when you just look within subjects, but of course we then have these practice effects. And the other problem is that many of the studies are of pretty limited duration. Long-term studies of 10 years or so are very rare, and there tends not to be a well-matched control group in this cohort. When we look at, later on in the course of illness, there does seem to be some evidence for a more rapid decline in cognitive function around the age of 60, and at least in institutionalized individuals. And the basis of this is unclear, but you could imagine it being partly due to the poor physical health in patients with schizophrenia, which becomes increasingly evident with age. And then also both the kind of lower starting point in terms of cognitive performance may contribute to this increased incidence and earlier onset of dementia that we see in individuals with schizophrenia. So we touched on this initially, but what are the consequences of cognitive impairment for individuals with schizophrenia? This is really, why do we care about it, and why should we try and do something about it? And there's a few reasons, really. So first of all, it makes adherence to standard treatments poorer. Partly resulted to this, it also increases the likelihood of hospital admissions. When those admissions do occur, they tend to be longer, and so thereby contributes, really substantially to the direct cost of the disorder. But probably, more importantly, the way that this really contributes to the morbidity and to the economic costs of psychotic disorders is that, understandably, this really is a major factor underlying both unemployment, the difficulties individuals with psychosis find in getting paid work, and also when they do get it, it tends to be in very poorly paid positions. So there we've discussed the nature of the problem, what cognitive impairment actually is, how it progresses, what its consequences are. What I next want to discuss here is, well, what might actually be underlying this? What might be both the etiology and also the potential pathophysiological mechanisms? So, if we start by thinking about genetics and, before the era of genome-wide association studies, a lot of what we came to know about schizophrenia, genetics, and that of other psychotic disorders came from twin studies. And when we look at twin studies of schizophrenia, we see a similar heritability of cognitive abilities both in schizophrenia as is seen in healthy controls. And when we look not just at twins, but at first degree relatives in general, we do see a significant deficit in cognitive function. So it's these gray squares. The higher up you are, the worse the cognitive function in comparison to healthy controls. And we see, again, across most domains, there seems to be this broad reduction in cognitive abilities compared to the general population. What about when we actually look at it from the polygenic approach? So we know that in schizophrenia, in most individuals, this can be understood as a polygenic disorder where we have multiple genes of small effect, increasing illness risk. And this model very much applies to cognitive abilities in the general population as well. And this heat map here has shown the correlation between cognitive abilities on the x-axis and various neuropsychiatric disorders on the y, where red is a positive correlation. And what we're seeing here with schizophrenia is this strong negative correlation in terms of these cognitive abilities here. So the greater your genetic risk for schizophrenia, well, not that this isn't within individuals, this is actually within the SNPs themselves, but the genes that are associated with schizophrenia are negatively correlated with the genes that are associated with cognitive function. And when we look at population samples, we see that a high polygenic risk score for schizophrenia is associated with worse cognitive performance, and vice versa, a low score for cognitive performance is associated with an increased risk of schizophrenia. And among individuals with schizophrenia, we see that cognitive performance is associated with the same polygenic risk scores for educational attainment and IQ that it is in healthy control populations. When we look at the relationship with bipolar disorder, something kind of very interesting pops out. First of all, that there seems to be a relative lack of a strong negative correlation with bipolar disorder in terms of the relationship between the genes for bipolar disorder and the genes for cognition. And this is, somewhat surprising just because the genes for bipolar disorder and schizophrenia overlap so substantially. And when that's looked at in more depth, that seems to be because when we look at the genes that are uniquely associated with each disorder, so don't overlap, then a really large proportion of those genes in schizophrenia seem to be associated with poorer cognitive function, whereas the opposite's true for bipolar disorder. So cognitive function appears to be, the one phenotypic component that really reflects a fundamental difference in the genetic architectures of these disorders. Now, when considering the genetic underpinnings, we've got to realize that these don't always imply a direct link. So if we think how individuals of a certain ethnicity may have less access to educational opportunities, then the alleles associated with this phenotype might still show a negative association with cognitive ability, but in cases like this, we're not going to really get useful information tracking the biological function of those alleles, but rather we want to think about the environmental mechanisms mediating the association between those two aspects. So, just as we know that there's a wide variety of environmental factors associated with psychosis, in the general population, there's a wide range of environmental factors associated with cognitive ability. And interestingly, these become of greatest importance in situations of socioeconomic disadvantage, where they basically mask genetic heritability. So ethnic minority status is, at least in the studies performed in the United Kingdom, one of the strongest risk factors for the development of psychosis. And it's ethnically minoritized individuals that also tend to have poorest educational attainment. And when examining the groups, there do seem to be examples of correspondence between these outcomes. So in the UK, again, it's those of Caribbean ancestry that tend to show greatest increased risk of developing psychosis and also greatest risk of poor educational attainment. And there also seems to be this very interesting ethnic density effect. So the impact of ethnicity seems to be the greatest when individuals live when they're both ethnic minorities, but also live in areas where they have very few individuals of the same ethnicity around them. And a similar effect has also been demonstrated in terms of cognitive testing as well, that there seems to be this even greater impairment picked up on testing in areas of very low ethnic density. And again, the kind of factors underlying these associations are still being understood, but it seems the association with greater socioeconomic deprivation, childhood traumas, and exposures to discrimination, both structural and interpersonal, all have the potential to play a role in explaining these associations. Other kind of factors associated both with psychosis, but also with cognitive ability seem to be urban environments. Like I say, this is sometimes driven by the greater socioeconomic deprivation, but even after controlling for that, there seems to still be this link, both with risk for psychosis, but also with risk for performing worse on tests of cognitive ability. And this seems to be in a variety of domains. And again, the specific mechanisms underlying this still remain to be really tied down, but in addition to deprivation, it seems that the pollution seen in urban environments may be another factor that could, have this kind of dual role in increasing risk for psychosis, but also cognitive impairments. We also know that cannabis use seems to play a role in risk of developing psychosis. And likewise, acute use is associated with clear impairment. Regular users also seem to appear worse on cognitive testing that's in the general population, but there's then this very surprising finding on the face of it that in people with schizophrenia, that seems that cannabis users quite often have better cognitive performance than the patients who don't use. It's counterintuitive, it doesn't match up with what's seen in the healthy volunteers, and the basis isn't really clear yet. I think there's two potential hypotheses. One is that it's basically a bit of a selection bias, that you can't be that actually kind of obtaining cannabis requires a fair bit of social savvy. So you've got to have your cognition relatively intact to be, getting the money to buy cannabis and then actually going out and buying it, having the motivation, the organization for that. And I think another alternative is that it's the kind of another type of selection bias, that the individuals who develop schizophrenia due to cannabis use maybe have less genetic predisposition. It's a more environmentally driven psychosis, and therefore maybe less genetic predisposition for cognitive impairments. So only when thinking about etiological factors, prenatal factors have long been associated with an increased risk of psychosis. So there seems to be a general association, or no, there doesn't seem to be a general association between cognitive abilities and evidence of infection when it's broadly defined. But with some infections, like influenza, which is illustrated here, it seems to be that the effects of infection on cognition don't really seem to be present in controls, the pairs of bar charts on the left. But when we look at actual individuals that have schizophrenia, their prenatal infection seems to have an impact on cognition. When we look at obstetric complications, though, the effect of obstetric complications on cognitive function seems to be fairly universal. So the top line is controls, the bottom line is people with schizophrenia. Y-axis cognition, x-axis number of complications, and we see this gradient. The greater the severity or number of obstetric complications, the greater the cognitive impairment in adulthood in both groups. Finally, the kind of cardiometabolic factors, they're perhaps not a risk factor for schizophrenia, but very much associated with the disorder. We spoke earlier about how individuals with schizophrenia seem to have a decline or an earlier decline in cognitive ability later in life. And a significant amount of this might be due to this increased burden of vascular risk factors, the increased prevalence of smoking, obesity, hypoglycemia, hypertension, all of which have adverse effects on cerebrovascular function. So we've kind of had a whistle-stop tour there of the etiological factors that seem to be associated both with schizophrenia, but also perhaps the cognitive impairments associated with schizophrenia. And so it seems that when thinking about causes, there's both that genetic component, but there's increased exposure to environmental factors that may reduce cognitive performance. So that's the etiological factors. Still thinking about what underlies the problem. How might these factors operate on a pathophysiological basis? So when we want to understand the biological basis, we do really want to get down to the molecular level, because this is where many of our pharmacological interventions act. But we can't take biopsies. Even if we could, behavior's many steps removed, and so a direct association might be masked. And we probably still want these non-invasive methods to kind of draw a path between the molecular process and what's displayed at the behavioral level. And if we think about a model here, so the kind of canonical microcircuit that's replicated across the cortex is this interaction between excitation of these pyramidal cells and inhibition provided by GABAergic interneurons. And it's this interplay that generates neuronal oscillations that we can measure with MEG and EEG, which those in turn are linked to kind of these macro scale cortical networks we can measure using MRI, which is in turn linked to healthy cognition. And understanding how various neuromodulators act on this pathway may provide us with a way of thinking about how to improve cognition in individuals with psychosis. So zooming in on this microcircuit, what might be happening at a molecular level in psychosis? And one hypothesis is that there's this imbalance between excitation and inhibition, that basically there's a state of disinhibition in the cortex, that there's reduced inhibitory drive. There's some support for that from post-mortem studies, but studying in vivo is challenging but possible. So that interaction between excitation and inhibition generates neuronal oscillations in the gamma frequency range. And in rest, we see that there may actually, in fact, be an increase in gamma oscillations, which you might expect in a case of cortical disinhibition in patients. That's what's being shown in this figure here. But our next question is, well, what does that actually mean when the brain's engaged cognitively? And what it seems to suggest is that there's this impairment in task-induced gamma oscillations. So while there might be a bit of an increase at rest, controls have this ability to increase gamma oscillations, which is impaired in individuals with schizophrenia, which again is consistent with this state of cortical disinhibition. We also see reduced mismatch negativity, which is something that is also consistent with this cortical disinhibition. At the behavioral level, models of this increased excitation, reduced inhibition, predict impairments in spatial working memory, which we then also actually observe in patients with schizophrenia. So if we say, that cortical disinhibition is present, what are the various potential factors that could lead to this? So we always need to think about dopamine with schizophrenia. This is how all our current antipsychotics operate. And what this is showing here is what the in vivo imaging studies of dopamine function have shown, which is this significant increase, particularly in the dorsal striatum of presynaptic dopamine function when we compare people with psychosis to controls. And when we think about the link with the cortex, there's strong links between striatal dopamine function. What this is showing here is how measures of striatal dopamine function are tightly linked to measures of cortical activity on the right. And so if we're thinking that, again, cognitive symptoms are more mediated cortically, this is one mechanism where striatal dopamine may still play a role. But a lot of work about cognition and dopamine focuses very much on the role of cortical dopamine, because cortical dopamine seems to play a role in attention, memory, executive function. And studies in, lesions of cortical dopamine function, whether that's in animal studies, people with Parkinson's disease demonstrate these impairments in cognition quite broadly, and pro-dopaminergic compounds, at least in disorders like ADHD, seem to have a benefit. The problem is that studying cortical dopamine function is pretty tricky in individuals with psychosis. It's a lot harder to measure than striatal dopamine, partly due to the much lower density of dopamine receptors in the cortex. This work by Nisabi Dargham's group, though, did seem to suggest that you get less dopamine release induced by amphetamine in the cortex. This is people with schizophrenia on the left here. And we see in controls, amphetamine seemed to induce a good amount of dopamine release in the cortex that's not observed in individuals with schizophrenia. And this seems to be related to cortical activation during working memory tasks. This kind of also makes sense in context of why, antagonizing dopamine isn't going to be that helpful if actually in the cortex we have a deficit of not too much, but too little dopamine. But how does this tie into that microcircuit we were talking about earlier, this link between excitation and inhibition? So dopamine does kind of enhance the excitability of these neurons, but it also enhances the excitability of these interneurons due to dopamine D1 receptors on these neurons. And the net effect overall seems to be for dopamine signaling to reduce pyramidal cell firing. So overall increases inhibition in this circuit. And so you can see how a reduction in cortical dopamine would again be contributing potentially to the state of cortical disinhibition I've been mentioning. So that's dopamine. But what other neuromodulators might be important when we're thinking about cognition? So acetylcholine plays an absolutely central role in attention and memory. We use acetylcholine boosters in the treatment of Alzheimer's disease. The treatment with anticholinergics can cause cognitive impairments. The prevalence of smoking in schizophrenia is huge, and people with schizophrenia say that this seems to help with concentration. And studies show in the short term, at least, that's correct. And similarly, PET studies of muscarinic receptors in psychosis have shown a reduction here in individuals with schizophrenia and link this to the presence of cognitive symptoms. And we'll see later that muscarinic agonism may be a potential treatment of cognitive symptoms in psychosis. Again, how may this be acting on this microcircuit? Sorry, quite a busy slide here. So we know that acetylcholine is potentially acting on both the nicotinic receptors and the muscarinic receptors. So the nicotinic receptors mainly act up here, where we have this kind of two interneurons in a row. So the effect of the nicotinic receptors seems to actually be to increase excitability because they're inhibiting an inhibitor, whereas the muscarinic M1 receptors seem to mainly promote activation of these interneurons, reducing that disinhibition potentially. And so we could think that reduced muscarinic signaling in schizophrenia could again lead to this cortical disinhibition. There's also very much a link with dopamine, again, both that we can see that the M1 agonism has the potential to actually increase cortical dopamine release, whereas M4 agonism here has the potential to actually reduce striatal dopamine release, which is, potentially what we're looking for if we're thinking about this excess striatal dopamine transmission within the striatum and this reduced cortical transmission. There's the potential that by modulating muscarinic neurotransmission, we're addressing both of these issues. So we've spoken now, about the nature of the problem, about the various etiological factors, how these might operate on a pathophysiological basis. But when we're in the clinic, we know this is a problem, but what can we actually do? So, like I said, while people in clinical trials, their cognition may improve at times with antipsychotic compared to placebo, a lot of this seems to primarily be due just to the improvement of positive symptoms. When we actually compare antipsychotics against one another, the literature is relatively sparse. So the kind of network meta-analyses that have been done need to be taken with a pinch of salt. It does seem, however, that there does seem to be perhaps some antipsychotics that may perform better than others. In this recent network meta, it was amisulpride and irazodone that appeared to come out on top, although, again, only a single study contributing to the estimate for amisulpride here. One thing that we can probably do, though, is really be considering the cholinergic burden of the compounds that our patients are taking. So this is showing here cognitive performance in individuals with schizophrenia, and the colors of these lines represent the cholinergic burden of the medications that they're on. And we see, a huge difference. This is someone taking no drugs with anticholinergic affinities in the blue line, the purple with a high score, taking, probably a couple drugs with high affinity for the cholinergic system. So actually being aware of the cholinergic affinity of the drugs that our patients are taking and acting to reduce that where we can is a very clinically obtainable option for improving cognitive function in our patients. So affective symptoms, depressive symptoms are often associated with cognitive impairment, and while just kind of non-selectively giving out antidepressants to individuals with schizophrenia doesn't appear to have pro-cognitive benefits, we know that treating depression more generally does appear to have cognitive benefits. And so looking at this in the future, whether this also seems to have benefits in psychosis will be very valuable, but it's at least very indicated at the moment just from the effective angle and may well have beneficial cognitive side effects. We spoke earlier about the vascular risk factors and addressing these, addressing hyperglycemia, hypertension, hyperlipidemia, all has the potential at least to potentially prevent further cognitive impairments developing. Sleep, I'm probably slightly cognitively impaired given got up at 3 in the morning today, and our patients often have similarly poor sleep patterns, and addressing this with them has the potential for really significant cognitive benefits. And cognitive remediation therapy, one of the few therapies that's actually looking to directly address this, again, seems to significantly improve cognitive test scores. It seems like, like a lot of the psychological therapy literature, sometimes difficult to, adequately control and account, for the practical effects that may be inherent in the therapy. But when this is done, it does seem that there is still a benefit, even though maybe on the small to moderate size. What about novel treatments, and particularly novel pharmacological treatments? So we're very interested in cannabidiol. Years ago, the largest phase 2 study showing that adjunctive treatment seemed to be potentially effective for overall psychotic symptoms. And although it was, very much not powered to assess cognition, in that same study, there was a trend improvement in some cognitive domains there. And again, in its efficacy in treating seizure disorders, that already is making us think that perhaps one of its mechanisms of action may be in reducing this purported state of cortical disinhibition in psychosis, again by increasing the activity of these cortical interneurons. We mentioned earlier the relevance of the cholinergic system for cognition and particularly cognitive impairments in psychosis. Some of you may be aware that it seems like muscarinic agonism appears to be an effective treatment for psychosis generally. There's been both successful phase 2 and phase 3 trials of a compound called xanomeline that's been paired with a peripheral cholinergic antagonist. So the problem with cholinergic drugs is they have terrible side effects because you've also got your cholinergic receptors throughout your periphery. And so there'd been early development of xanomeline that seemed to both improve psychotic symptoms, but also improve cognitive symptoms in these early trials. But that ceased due to the high side effect burden. But recently this has been paired with a peripheral antagonist, so you still get potentially the beneficial central effects without the side effects. And in the recent trial, since the development's restarted again, there appears to be improvements in cognition, but further work needs to be done here to see whether, again, whether this is specific to cognition or more reflects just the big improvement in overall symptoms that we see. Again, if we think about the mechanism of action via which muscarinic agonism might help, again, one option is increasing interneuron activity, both directly or potentially via dopaminergic mechanisms as well, and so potentially reducing a state of aberrantly increased EI in psychosis. Then finally, when thinking about other not cholinergic, other pharmacological interventions, when we were talking about dopamine and acetylcholine, we're, always a few steps removed, but what about actually kind of directly targeting glutamatergic transition? So one interesting option is looking at glycine. So glycine is both an inhibitory neurotransmitter in its own right and a co-agonist at the NMDA synapse. So it's needed for glutamate to activate the NMDA synapse. And there's some interesting compounds that are looking at the glycine transporter, looking at what happens. Well, if we block this GlyT1 here, then we should be able to increase the amount of glycine in the synaptic cleft. And that has the potential to kind of, again, reduce this cortical disinhibition, both by direct inhibitory impact of glycine, but also by particularly enhancing the activity of interneurons by increasing the activity of the NMDA receptors on those interneurons here to kind of overall address a state of cortical disinhibition. Studies here are a bit kind of earlier along than the muscarinic studies, so this is a recent phase 2 study, but interestingly here being developed not for the treatment of psychosis in general, but specifically for the cognitive impairments associated with psychosis. And this is showing, basically increasingly beneficial effects on cognition as the dose increases compared to placebo. Again, here it's these bars at the top, which are the higher doses compared to the lower bars, which are placebo. So encouraging phase 2 results here, and phase 3 studies ongoing, specifically targeting cognition. So there's a range of both, existing options, what we can do with kind of our current toolkit to try and optimize cognition in our patients. But there's also, several exciting options on the horizon. So finally, what are some of the main outstanding questions when we're looking to understand cognitive impairments in psychosis? So first of all, this question of, does the pathophysiology of cognitive impairment vary? Because this would probably inform what treatments work for which individuals, this general theme of precision, personalized medicine in psychiatry. And in clinical trials, initially, one question is, do we want to be trying to stratify, to develop some kind of biomarker that's going to guide, which could we say that actually, it's in individuals with, a measure of cortical inhibition from EEG or MEG that are potentially going to benefit the most. And this ties in very much, when and in who are these interventions going to be both beneficial? Do we really want to be targeting early in the course of the illness? Do we want to be targeting those with the greatest cognitive impairments, or those with the greatest potential to benefit, or potentially are those with the least flexible impairments that are least likely to benefit? It did seem in the recent trials of the muscarinic agonist that it was actually those with the most severe impairments at baseline that benefited the most in terms of their cognition from treatment. And then finally, we're not really, just interested in cognition in and into itself. We're interested in what it means for people's lives. And so really kind of mapping the nature of that relationship with increasing precision, I think, is important, because it's not necessarily linear. We've seen non-linearities in terms of symptoms in cognition. And it may be that we see something very much between cognition and function. You can imagine that there's almost a kind of tipping point via which, if you've got someone with an IQ, say, of 90 and an IQ of 110, maybe it doesn't actually make that much difference to one's general functioning in life. But once we get down to kind of the lower end of the scale, it potentially begins to have much more impact. And so just shifting, a smaller shifts there in terms of cognition may have greater impacts on functioning. So in conclusion, what's the problem that we've got? So we've got this widespread, important impairment in cognition in people with schizophrenia, and it seems really key to their functioning, which is what we care about. What underlies the problem? It seems, a lot of what underlies the problem is what underlies the problems in schizophrenia more generally, these kind of general genetic and environmental factors. But our understanding here is increasing. and how can we fix the problem? Well, there's several things we can do already, but encouragingly, it seems that there's new things on the horizon as well. So that's all. Thank you very much for your time today. It's been a real pleasure speaking to you. Thank you. Bye bye.
So, Robert, don't disappear. We do have questions from the audience. I've certainly got lots of questions, but I think we'll go with what the audience wants to hear about. Thanks for sort of getting up so early. Fantastic. You've got the jet lag without the benefit of being here, unfortunately.
Yeah, I've got young kids, so it's not too abnormal, actually.
Certainly very interesting to look at the factors relevant to cognition, because it's certainly been very important in terms of functional outcomes and the way that they impact on patients' abilities to function in the community and to function independently. We've got questions about exercise improving cognition, but also questions, and I'm going to try and link a few, CRT and the benefits of that. Did you want to comment on other forms of treatment? You've touched on some of the novel treatments. I think the muscarinics are looking very interesting, certainly, but we certainly need more specific drugs there. But maybe some of these other types of interventions.
Yeah, no, I think, I think, like I said, there's been a huge amount of work in cognitive remediation therapy, and the meta-analyses do seem to show a significant benefit there. Like with many psychological interventions, kind of drilling down to the higher quality studies and like pharmacological interventions does seem to reduce the effect size somewhat. I think the biggest challenge with, again, it's a common theme, is actually the implementation. The manpower required for delivery, in particularly in under-resourced settings. Exercise, again, here I think the study quality, again, and quite often the lack of appropriate control conditions is the thing that makes interpreting the literature difficult. However, because it's an intervention that, if done correctly, probably doesn't have too many significant risks, and also likely has benefits in other domains, it's one of those things that there seems to be no reason not to encourage. That the difficulty really is interventions that actually lead to sustained uptake of exercise. That's really the challenge, isn't it? Even if we're certain that exercise is beneficial, getting an intervention that gets anyone, let alone people with a disorder that profoundly affects motivation, to stay consistently engaged is a real challenge.
Been told I can only get one more question in, so I like this one. Is there a greater role for clinicians specialized in the assessment and treatment of cognition, such as neuropsychologists? Well, from my perspective, absolutely. And we've had a neuropsychologist on our unit, but I'd like to hear your perspective as well.
Yeah, so I think, I don't know if you've had the same thing in Australia with the, maybe that we've probably seen in the UK with just, increasing resource burden and difficulty in delivering even kind of basic standards of care. So my feeling would actually be that this should be something that is part of routine care, that basically, psychiatrists and other members of the team should be developing skills. And, what we've seen is that actually the cognitive impairments quite often aren't in, a really specific domain. They tend to be global, and we can get fairly accurate measures of global cognition fairly quickly. But this isn't something I think that's ever really, it's not something that we're trained as psychiatrists or as nurses. But I actually think, particularly if we get treatments, pharmacological treatments that can be delivered in the clinic, I think, it's going to be something that everyone in psychosis services should be having some measure of cognition. And I think that's going to need to come about from actually it becoming something that we're all familiar with and all able to do, rather than becoming something that's specialized. There's definitely, you know, a huge role for neuropsychology helping to lead in this. But I think actually we don't want it that it's just the kind of preserve of the few being able to assess and understand cognition.